Good morning. I'm glad to be here. As mentioned, my name is Prasad Adusumilli. I'm a thoracic surgeon at Memorial Sloan Kettering Cancer Center. Our laboratory research is focused on studying mesothelioma, immunology, and immunotherapy. Most importantly, what is known as the CAR T-cell therapy for the clinical trial. And my co-chair is Dr. Hassan. Raffit Hassan, most of you know, has done extensive work for the last couple of decades on targeting mesothelin by multiple methods. And he's at the National Cancer Institute. He's the head of solid tumor oncology there. So I just want to update you what we have done, obviously, with the Mesothelioma Applied Research Foundation has funded us initially when I was a junior faculty. So as we know, just to give you an overall view, you all know that 2003 was first when the dual chemotherapy was approved with a median survival of 12 months from diagnosis. And the immunotherapy, the two checkpoint blockades combination was approved in 2021 with a median survival of 18 months from diagnosis. So that's where we stand. Immunotherapy, obviously in solid tumors, 1 in 5 patients respond excellent, but the other, even other, lung cancer, bladder cancer, beyond that, the responses are not seen. But when we, Elizabeth Zaffe group at Johns Hopkins, when they looked at 5,500 solid tumors, the two markers we look at to see if immunotherapy is going to work, mesothelioma, unfortunately, is the lowest of all the tumors in general. And Keytruda, the anti-PD-L1, PD-1 agents that are tried in the second line after the first line chemotherapy has shown a median survival of 10 months. So that's where we stand. So in the laboratory, we have in addition to studying patient tumors, we have a good mouse model. As you can see with the mesothelioma, this is a tumor encircling both lungs and heart. And that's where what we have done is what is called a CAR T-cell therapy. Essentially, our immune cells recognize anything that doesn't belong to our body, but the cancer fools the immune system. So the CAR T-cell therapy is where we take the peripheral blood in the blood bank, isolate the immune cells, T cells, and genetically engineer them so that they can recognize a protein, which is myself and Dr. Hassan is targeting mesothelin that is expressed on mesothelioma. If we can make into billions of cells, the immune cells of patients' own immune cells, and we give it back to the patient as a blood transfusion. But as many of you know, the mesothelioma is in the chest, so what we have done different is directly giving to the chest cavity rather than giving to the blood. There are several scientific and immunological benefits. And even when we give within the chest, the immune cells that are genetically engineered, these CAR T cells, cancer exhausts them. After a while, the immune cells get exhausted. So that we use checkpoint blockade in the mice to reactivate the CAR T cells and keep them going. These are some of the patient examples where you can see on the screen, left-hand side for you, what is lighting up on the PET scan. Once we give CAR T cells, at least 3 doses of checkpoint blockade, though the patient in the middle is the patient with multiple metastases throughout the body. After giving CAR T cells, survived for about 2 years. And now we have a 5-year, 6-year, and a 4-year survivors. This is after they initially failed chemotherapy and some of them failed immunotherapy. So this is not from the diagnosis, this is from the CAR T cells. We have treated about 41 patients to date. And as shown in the middle of the 2 boxes, about 2/3 of the patients received these CAR T cells as a second line after chemotherapy, and 1/3 of the patients received after 2, 3, or 4 lines of therapy before. The median survival from the day they received CAR T cells about 16 months. But most importantly, what we translated to clinic, give a dose of CAR T cells, patient's own immune cells, genetically engineered, and then give checkpoint blockade or Keytruda to reactivate them. The median survival is 18 months. So this is very encouraging, and this patient median follow-up is about 52 months. And among them, the PD-L1 negative, technically PD-L1 negative patients are not great responder to immunotherapy, but as you can see, close to 2-year median overall survival from receiving the day of CAR T cells. And these patients from diagnosis are a median survival, that is half of the patients survived more than 3 years. We are getting ready to write this manuscript because this is encouraging. Again, this is 10 years of work done from 2010 to 22, step by step, going back between the mice and the clinical trial patient samples that we have translated. But happy to say, most importantly, which is very important to this group, functional quality of these patients is excellent. We have videos. I do not have permission to show you. We have at least 10 patients after the 15 patients that is more than 3 years. Unless we tell them on the scan they have cancer, they do not feel anything. Functionally, they keep up the weight. and quality of life is good. This is something different. When we reach constantly in our body, the immune cells, cancer cells are fighting. But I think we reached a state of equilibrium. We are not there yet to completely eradicate mesothelioma, even by this approach, because the cancer is still there on the scans. And of course, these carefully selected, carefully conducted, high-risk clinical trials. This is what we need to do, phase 1 and phase 2. So I think we reached a state of cancer equilibrium, but the next step, we have done some other modifications, which we hope to start the clinical trial. As we learn, we can modulate more genes, as we are learning specifically mesothelioma. So the next clinical trial, we will be modulating at least 4 genes. The results I have shown is 1 and 2, but at least 4 genes. FDA is very approving of these therapies because the safety that we have shown. To date, we have treated 65 patients, and we have not had any treatment-related, this particular treatment-related major toxicity. So hopefully FDA will approve our next 2 genetic changes that we are going to put in the immune cells and move forward. So that's a brief introduction to what we have been doing at Sloan Kettering. And Dr. Hassan.
Thanks, Prasad. So I don't have any slides, but I just wanted to share some thoughts about novel therapies for mesothelioma and in general regarding patients. So as Prasad mentioned, we have also been focused on developing therapies targeting mesothelin for a long time, used different approaches, and over the last several years we are using again, T-cell therapies targeting mesothelin, similar to what Dr. Adusumilli mentioned, where we take the patient's own T-cells, we modify them in the lab, and then infuse them to the patients. But what I want to talk about is, in general, if you are a mesothelioma patient, what are the options in terms of clinical trials or novel therapies? In general, in patients who are surgical candidates, and we'll hear a little bit more about that, but especially in patients with peritoneal mesothelioma, in general, we believe that surgery is a key component which has clearly been shown to improve survival in peritoneal mesotheliomas, where the surgeons are able to remove the vast majority of the tumors and clearly improve survival, and that may be one of the reasons patients with peritoneal mesothelioma have a significantly better prognosis. So usually I see patients as a medical oncologist when they are newly diagnosed and where we feel that surgery may not be of benefit. We, of course, have the patient seen by our surgical colleagues. So in mesothelioma, at least we have some options these days. For a long time, it used to be a combination of 2 chemotherapy drugs, which Pemetrexed, Alimta, and cisplatin or carboplatin. But over the last 5 to 10 years, there has clearly been patients with mesothelioma who respond to immunotherapy, and which culminated in the approval of immunotherapy a couple of years ago by FDA approved it. So for our patients, there are options when they're newly diagnosed and surgery is not an option. And the most common type is the epithelial mesothelioma, where the patients, depending upon their circumstances or depending upon the clinical condition, can get either chemotherapy or immunotherapy upfront. And if they respond to it, that's great. If they do not respond, then we can switch it. So we have 2 different type of drugs that the patients can have. If it is sarcomatoid mesothelioma, then clearly immunotherapy is the preferred upfront treatment. So in our practice over the last 2-3 years, we have seen changes in the way the patients come to clinical trials. In general, most of the patients either have had chemotherapy and more commonly have had chemotherapy plus checkpoint inhibitor. So in many of the referral centers, the patients are seen after they have had standard therapy. So that's where the questions come up. What are the novel therapies? What can we do if chemotherapy and immunotherapy is not working? So for that, there are a lot of clinical trials. As you know, the clinical trials are called phase 1, phase 2, phase 3. Phase 1 trials are the very early trials, which are based on activity in animals or in the lab, and they have gone significant rigorous evaluation in the lab to the point where the physicians and the scientists bring them to the clinic, and it's a very regulated process, both at your own institution, but ultimately these type of trials are approved by the Institutional Review Board and of course also approved by the FDA. So there a lot of thought goes into the starting a phase 1 clinical trial. And the phase 1 clinical trials are usually first in human study. These are drugs or treatments which are done for the first time in patients, so they have a lot of safeguards. And usually phase 1 trials are done at bigger hospital, tertiary hospital, where there is sufficient infrastructure to monitor the patient. And that's where many of you will, if you participate in phase 1 clinical trials, get to know your research nurses who are very knowledgeable about these type of studies. And these trials can be very intense, such as the most intense trials are what we call as the CAR T-cell trial or the T-cell therapy trial, where we take the patient's cells, modify them, and give them into the vein or into the pleural fluid, as Dr. Adusumilli mentioned. Phase 1 trials, we need to monitor the patients very closely. We can treat only a certain number of patients at a time, because if you see a side effect in one patient, then you have to slow down the number of patients you enroll and watch the patients very closely, because we are monitoring the patients closely for toxicity. So in phase 1 trials, when I see patients, I discuss the potential benefits. Again, these are first in human trials. We can say what we see in the lab, so the patients understand that it is possible they may not get any benefit from the drug, but it is also possible that they could get side effects from the treatment, and sometimes they need to be in the intensive care unit or other complication. But we do have safeguards in place, and we talk about that. We monitor you very closely, so that is a good situation where everyone is keeping an eye out for the patients for any potential side effect. So phase 1 trial in general requires more commitment from the patients, and we greatly appreciate the time and energy they spend traveling many times from all over the country or staying in the hospital for a month or so, depending upon the nature of the trial, and agreeing to participate knowing that they could get side effects and the benefits are not clear. So, but the phase 1 clinical trials are the key. So all the drugs patients get, nivolumab or ipilimumab or chemotherapy drugs, all drugs that are approved go through this process. And so I think it's very important to participate in novel therapy trials and hopefully get benefit. But many of the patients that I see say, I understand that I may not get benefit directly, but it will help other patients down the line, which is really important. So if we do the phase 1 trials and we see the outcomes are that we see some potential benefit, and then we decide to go to the next stage where we treat more patients. We know what the dose is, what is the right dose, what the side effects are. So typically we go to the next stage, phase 2 trial, where we might treat typically 20 to 30 patients and to see if we really see the response and further define the side effect. And most of the drugs which do not progress further are at that stage where if you see a promising result, then we go to the phase 3 trial, but if we don't, then we stop the development. But even in trials which do not work, we learn a lot that helps develop new drugs. And if the drugs show similar enough activity, then they go to the phase 3 trial. These are big trials, usually 300, 400 patients, where patients get randomized to get the new drug versus what is considered as standard of care drug. And there we are looking at different objectives, such as what is the overall survival, and these are the trials, if they are positive, lead to the approval. So in terms of mesothelioma trials, there are trials which are specific to mesothelioma patients, for example, targeting mesothelin, which is a protein expressed on mesothelioma cells. But many of the drugs which are approved, many of the novel therapies don't necessarily have to be a mesothelioma specific trial. For example, the 2 drugs which are approved, pemetrexed and cisplatin. That clinical trial was initially not designed for mesothelioma patients. While they were doing the phase 1 trials, they had a few patients with mesothelioma, and Nick Vogelsang and others at the time saw that, well, we see some activity in mesothelioma patient. And then they shifted that phase 1 towards a mesothelioma trial, leading to the phase 3 trial, leading to the approval of Alimta in mesothelioma. But that trial was for patients with solid tumors. It had nothing to do with mesothelioma. Luckily, there were a few mesothelioma patients in that study, and that led to the approval. Similarly, the other drugs which are approved for mesothelioma, the immunotherapy, was for any solid tumor. It was not specific to mesothelioma. But once we saw hints of activity in mesothelioma, that led to its development. So in terms of some of you who are looking at trials, clinical trials, that if you have a mesothelioma-specific novel therapy trial, that's great. But if many of the cancer centers, many of the local institutions will have novel therapy trials which are for patients with advanced cancer, solid tumors, and I think those trials, although they may not be mesothelioma-specific, they could be beneficial and show activity, and if sufficient activity leads to development. So I would say that these are things that need to be discussed with your local oncologist is the key. Even if our patients go on clinical trials, we maintain very close relationship with the local oncologist so that they are aware of the treatments that the patients are getting and what the potential side effects are. And once they go back home, we can have a close relationship with the local oncologist, and we can inform them of some side effects that we might be anticipating and have that close connection with the local oncologist and patient. So in closing, I would say that it's very important to participate in clinical trials, but get more knowledgeable about the trial, and usually your best person to know more about are the research nurses, because they are totally involved with the trial, and they know what are the patients who might be eligible or not, and they are the ones who always remind us what to do once we are treating patients. So I think research nurses, patient coordinators, these are important contacts for any of the clinical trials. So that's some of my thoughts. So I think Dr. Adusumilli and I will be happy to take any questions from the patients or anyone else.
This is your time to ask questions. Yes, sir.
Yeah, I just have a question in general about CAR T and where you see that right now. I don't know how long that's been in the works, but do you see the CAR T kind of being the best once you've exhausted all the other already FDA-approved types of trials or medications? Or how do you see CAR T, and when do you see CAR T being maybe moved to a next phase? Do you see any potential for progress? I think it's in phase 1, I'm not sure, but if you can just explain a little bit where we are with that,
sure.
I appreciate it.
So CAR T cells are clearly active in blood cancer. So, a single dose of patient's own T cells, which are modified, can completely eradicate lymphomas or myeloma. So there in the blood cancers, it has been, transformative. And patients are living longer and getting cured with a single infusion of the CAR T cell. But blood cancers are easier in a sense because the tumor cells are circulating in the blood. So once you give the CAR T cells into the blood, they see the cells, kill them, and these T cells can survive longer. But solid tumors are very difficult. Right now, I would say CAR T cells thus far have not shown sufficient activity in solid tumors. Recently, there was a trial in pediatric cancers where the CAR T cells in solid tumor showed activity. But right now, I would say the CAR T cell field is still in what we call as early stages. We're having some success, but not a lot of success yet. And that's why our group, Dr. Adusumilli and others, we are working hard, because if we are able to succeed with CAR T-cell in mesothelioma, it will have a huge impact, not only on mesothelioma, but many common cancers, ovarian cancer, pancreatic cancer. So that is the holy grail right now, how to make the CAR T-cell work. We're making progress. We are seeing some patients with responses, but I don't think we are at a stage where we'll get an FDA approval in the next few years, but we are making progress one step at a time.
I agree with Dr. Hassan. Obviously, this is an investigative stage. That's where we are. But this investigative stage is based on 10 years or 20 years of work, and we are glad to explore tumor immunology in mesothelioma. But as I mentioned, our immune system can only fight up to certain dose. After that, the enemy will take over. But having said that, the advantage of CAR T cells, what Dr. Hassan explained in leukemia, lymphoma, myeloma, they targeted one protein, and most of the cancer cells, almost 99% of the cancer cells express that protein, and also the liquid tumors are much more easy to treat. Solid tumors, mesothelin is expressed at a high level, but not 100%, that's number one. And two, currently we are tilting the balance by giving CAR T cells, genetically engineering. How it is different from chemotherapy or even the checkpoint blockade immunotherapy, we call it as a living drug. Meaning, if I had a headache and I take aspirin, in a couple of hours, the aspirin levels in my blood goes up, and after a few hours, it gets excreted. Whereas immune cells, once they see a target protein, one cell will divide into thousands and millions and billions of cells. So it's a living drug, meaning that was the dream in leukemia lymphoma that was achieved if we can give one dose. And those are the patients that failed multiple lines of therapy, 3 to 6 months survival, but for years they're doing well, not requiring any therapy, good quality of life, cancer is completely gone. Because if we can engineer the immune cells to recognize and they keep proliferating in the body, they keep the cancer at bay or eradicate. But in solid tumors like mesothelioma, there are several hurdles. We are not there yet. We are learning from all these clinical trials, so it's a still investigative stage. But on the other hand, we did benefit from what they learned in leukemia, lymphoma, myeloma. It used to be 2 to 3 months after taking the blood, genetic engineering, giving it to the patients. But now companies can do it in 1 week to 10 days. Costs are coming down. And we learned a lot, and all that knowledge we are benefiting and bringing into mesothelioma, but still in investigative stage. So.
Hi, is there any reason to think that the same concept would apply to peritoneal meso?
Yes. Yes. Yes, it could apply to peritoneal, and we, at least in our trials, we also treat patients with peritoneal mesothelioma. I think the biology is the same, and they express, for example, mesothelin. So yes, so we are including both patients with pleural and peritoneal mesothelioma.
Do we have any other questions from the audience? Rich, would your question apply here too?
No, right.
Okay. I have a question. We did a meso TV some time ago about the truck T cells. What is the difference between the CAR T cells and the truck T cells?
Yes, so the drug, so drug is a rather cute name, but it is basically, the principle is the same, that you take the patient's cells, modify them, and then infuse them back to the patient. So without getting into the details, with the CAR, there is one signaling domain, whereas with the truck, there is more than one. But overall, I would say the principle is the same. You target mesothelin, you take the patient's cells and modify them and inject them. But there are also CARs which are being modified in different ways. So I would say it falls into the same class of drugs.
So with the genetic engineering, typically I'm allergic to pollen. Once the spring starts, when I go there, my T cells will recognize the pollen, but the other immune cells will come and give the boost for me to go after whatever are allergic reactions, or in that case, cancer. So immunology in the last 50 years, we learned what are all the other cells doing, what are the elements. And now with the genetic engineering, we can put everything in the T cell. So the CAR is initially targeting a protein on the cancer cells and put in a couple of elements. But as we are learning, we can do multiple genetic engineerings. TRK is one aspect of it. And now within the CAR, as I mentioned, the next trial, we are going to do 5 different modifications within the genetic engineering. And now people are going it even up to 8 to 10. So that's the advantage with one of the, when I said living drug and immune cell. Instead of giving one aspirin or one cisplatin, we can make all these changes within the immune cells that's going to stay in the body, provided we can do it safely and provided we can increase the efficacy. So these are different versions of CAR T cell, TRK, and then what we also call armored CARs. So.
Thank you. We have another question.
Hi, Dr. Hassan. Nice to see you outside of NCI. For those of you who don't know me, I've been a 22-year peritoneal survivor, and Dr. Hassan is studying me. And I've been around a lot, and there are many new faces here, and there's lots of crazy big words that many patients don't understand. And I love the way Dr. Sternman in the last session talked about, well, you can do surgery, should you do surgery? And we were talking about clinical trials, and clinical trials are really important for science because we have to improve what we know, and we're such a small population of patients with a rare disease that the science is really important, and recruiting us into clinical trials is important. So my question is, based on your knowledge of the field and patient care, that we can participate in clinical trials, when should we? And how should we? Or like, how do you make those decisions?
Thanks, Sue. So in terms of clinical trials, there are different types of clinical trials. So there are clinical trials which are aimed at learning more about mesothelioma, about the biology of mesothelioma. So once we learn that, we can develop better therapies. And many of us have trials, what we call as natural history trials, and many of you have participated in that, where you see us or some other institution, another investigator, you donate your blood, your tumor tissues, the extra tumor tissues, allow us to study that. And that has been extremely helpful in bringing out new things about biology. For example, learning about the BAF1 mutation, the BAF1 mutations which are in the blood, BAF1 mutations in the tumor, learning more about mesothelin. So those allow investigators to develop new things. So those are the natural history trials. So that would be any patient who comes in, even if they come to see us for consultation, they can participate in that. And so far, almost always the patients are very generous and willing to donate their tumor and tissues for research. The other type of trials are more longitudinal studies. For example, patients who have a germline BAF1 mutation, they are at increased risk of developing different cancers. So we follow some of these patients long term so that we can detect if they are at risk for getting other cancers, we can detect it early, monitor them very closely. So there are other trials, and for that, patients or individuals can participate at any time. Then the other category of trials are the therapeutic trials, which are the treatment trials. And some of the treatment trials, as we'll hear about later, are even for newly diagnosed patients, because those patients might be getting some novel therapies up front before their surgery. These are called window of opportunity trials, where we have a patient who may be eligible for surgery, but before they get surgery, they get the drug, whether it's immunotherapy or some other treatment, and then we can, at the time of surgery, look at the tumor and see how we have modified the tumor. So there can be trials for newly diagnosed patients also, so it depends. But most often, at least as medical oncologists, we see patients after they have had standard treatments, which today would be defined having chemotherapy and immunotherapy. But I would say, even if you are considering a clinical trial, it's better to look at some of those early on, because for some of the trials, such as the CAR T trials, it takes 2 to 3 months or more to make the drug. So if we take the patient's blood, then we have to make the CAR T. And that process is complicated, and it could take 3 to 4 months just to make the drug. So we try to see patients early on while they're getting regular treatments with their doctors, so that if they're eligible, we get their blood and start making the drug, so that when we need it, it is ready. So in general, when you enroll on clinical trial varies. If it's a natural history or it is a screening study, you can do it anytime. But for treatment histories also, it is good to kind of think about it early on, and so that if we have to make the drugs, we can do that. And many of the medical oncologists that you'll be seeing are familiar with it, or you can bring it to their attention. And so it varies.
We have a question from the online chat. The two of you represent two different institutions, the National Cancer Institute and Memorial Sloan Kettering Cancer Center. Is it possible to compare the different approaches to CAR T cell production and application between the NCI trials versus the MSK trials?
Yeah, we constantly do that. I mean, these kind of meetings and conferences are a great place for us to meet and discuss. Dr. Hassan has been a leader working with Ira Pasta on describing this mesothelin and targeting other approaches. There's so much I learned from that studies as well. And within these studies, again, we analyze the immune cells, why certain patients responded well and why some patients did not. And we analyze the biopsies and the peripheral blood. And again, same thing Dr. Hassan has done in the recent manuscript. So that comparison, direct comparison, we're all different human beings. Each patient is different. But we're having said that within the factors of the tumor, immune cells, and other factors, we do compare our results, not only the results, but also the samples, and learn from it. So,
I would just like to echo that, and I think because mesotheliomas, the investigators or the physician scientists who work on mesothelioma, we're a close-knit community. We get to see each other, learn from each other's trial, and I think that has been very helpful for the field.
Several years ago, I heard that when they're putting the T cells back into the body was a significant event for the body. Can you address that? Is that a big problem?
Yes, so that is a big problem because we give a lot of T cells. And once the T cells see the tumor, they proliferate. As Dr. Adusumilli mentioned, these are living drugs. So these T cells increase in significant numbers. And in some patients, it can lead to significant side effect. The most common side effect is what is called as cytokine release syndrome. Basically, your body produces a lot of substances that can cause fever, they can cause your blood pressure to be low, can cause difficulty breathing. But all of us now have a lot of experience in treating those symptoms. And so sometimes the patients require special medicines for this. And the other side effects are sometimes patients can get inflammations around their lung or inflammations in their belly. So those are some of the side effects that we keep a close eye on.
thankfully, again, we learned a lot from leukemia, lymphoma, myeloma trials. This used to be a big issue. When patients got CAR T cells a week later, when they're proliferating, reached the peak, very high fevers, patients going to ICU. But it now became such a standard of care, like many of the physicians and nurses can treat it. And obviously FDA approved as a standard of care in those trials. And that's where a lot of knowledge we learned that we don't have to repeat again this in the mesothelioma. How to safely manage, why patients are getting high fevers, when, what is the time period that probably they're going to get the fevers. And that's why we ask the patients to stay close to the hospital, major centers, at least in the first few weeks, so that we can immediately recognize and act upon it. So.
Do we have any other questions? Okay, thank you very much. Oh, we do have one more question.
Hi, just a quick question. Are there other protein targets for CAR T cell therapy that have been investigated? And I guess a general question, when patients are diagnosed and they have their tumors analyzed, are they are the expression levels of mesothelin quantified or distinguished in any way? Do you think that might have an effect on their response to these kinds of therapies, or is it pretty much highly expressed across all mesotheliomas, pretty much the same throughout patients?
In terms of, there are other targets for CAR T cells in solid tumors, like other targets, HER2 and others. But mesothelin is interesting because it is expressed in many solid tumors and has low expression in the normal mesothelial cells. But sometimes there could be expression in the lung, and so that's something we need to keep an eye on. In terms of, as Dr. Adusumilli mentioned early on, that if you have a mesothelioma tumor, maybe 90% of them have mesothelin, but there are also some cells which may not have it. So, or they may have it at low levels. So for some of the clinical trials, for example, the trials that we do at NCI, we check the patient's tumor for mesothelin, and by pathology, just want to be sure that there is enough mesothelin for the patients to go on the study and get benefit. But in general, mesotheliomas have a lot of it, but at our institution, we still test it before enrolling a patient.
Just to add that in addition to looking for other targets proteins, now with the genetic engineering, we are at a stage we can target 2 or 3 different proteins at the same time in the same immune cell. That's one approach we are doing. Second is we learn from in mesothelioma, mesothelin is expressed high, but in lung and breast cancer, the cancer cell keeps it inside. For our approach for the CAR T cell to recognize, it has to be expressed on the cell surface. So now our lab and others have been doing this to how to bring it out. If the mesothelin is inside the cell, how to bring it out to the cell surface so that immune cells can target. So in addition to additional targets, there are other approaches, genetic engineering, we are doing that already in leukemia, lymphoma, myeloma, they are in clinical practice already, those approaches.
One more question. I'll get there eventually.
Hi, my name's Locke. It's really nice to meet everybody. I'm a patient. Was diagnosed 2.5 years ago working with NIH and also out of City of Hope in Southern California. One thing that is good, and I don't want to, I'm a little confused as a patient. It seems like things have been fairly static for 20 years in terms of chemotherapy, and then most recently there's been a development with immunotherapy as another FDA approved. But now it seems like there's a proliferation of type of treatments that are people going after CAR T, targeted therapies. I mean, it's great that as patients we have these options. It's a little confusing though also with these options. And it seems like it's actually really hard to find someone that's kind of like the front door to figure out what other door do you go through. You know what I mean? And you guys are all kind of, in some ways, separate pillars. And it's great to have these symposiums, but what do I do when I go home? Do you know what I mean? Because a lot of these doors are kind of one-way doors for us. So when we go through, it's like, well, do I do a chemo plus a double immuno? Do I do, you know, whatever neoadjuvant, you know what I mean? Post-adjuvant, you know what I mean? Whatever all that stuff is, right? And so it just seems like a lot of different options. Obviously, every patient is different, but it doesn't feel like I have a Sherpa to kind of help guide to go through. Do you have any advice on that, and where do you think that's kind of going?
So that's a great question. So I think that you're right. So there are a lot of options, which is good, a lot of investigation going on in mesothelioma. Then the question is, how does patient figure out which study to do? Should I do a study close to home? Should I do a study at another place? And what are the advantages or disadvantages of participating in a particular clinical trial? So if we have patients for which there are standard therapies, you know, in my practice, I would say that if you're newly diagnosed, surgery is not an option, then we have 2 FDA-approved therapies. And if you want to be closer at home, spend time with your family, we know what the side effects are, we know what the benefit is. So I think there it's a little bit easier to say because you could say, okay, you could get this therapy with your local oncologist. You don't have to leave your home. You can continue at work. And these therapies have been shown to have benefit, and we know what to expect in terms of side effect. Then the question comes, you have had the chemotherapy, you had the immunotherapy, what next? And then that's when you look at clinicaltrials.gov or talk to the foundation, and they might tell you there are these 4 trials at different institutions. So I think in that case, it required discussion with the physicians or investigators at those sites to get a better sense of, is it a phase 1 trial, is it a phase 2 trial? If it is a phase 2 trial, has it shown some benefit? So I think there is no easy answer to that. And you might hear, okay, this went through the phase 1, we saw some activity, and we know what the side effects are, so that might make it a little bit easier from the patient's perspective to participate in. But many times we don't have that information, and then you have 3 different novel therapies in phase 1 testing, and then I think that's where you need to have a discussion with your local medical oncologist who knows you the best and can be your advocate and kind of get an overall sense what might be appropriate for you. I don't know if that answers the questions fully. No, I got it. So I think your question, your comment was that many of the local, it's such a rare disease, and many of the local medical oncologists might not be familiar with what's going on. So I think that is true, and I think maybe that's where things like the Meso Foundation might be, because they keep tabs on what's going on throughout the country. They might know what's going on in California or New York. So sometimes the foundation nurses might be helpful to tell you what the different studies are. And also many times if you talk to one of us, for example, we might say, oh, you are in New York, it may be better if you see Dr. Adusumilli or Dr. Zauder, or at Memorial, they're doing similar studies. There'll be less disruption to your family, and that's a reasonable option. So many times we do that, try to see what might be a good option for the patient locally.
Thank you to both of you. We really appreciate it.